Good. So thank you for the introduction again. And I will say something about the first wave and what will happen next. But before that, I have to emphasize that everything that I will say is my personal view. It is not an official view of any of the institutions that I am affiliated with, and in particularly not the Croatian government, where I'm only the informal advisor. So if I bring you back a couple of months in January this year, we were all looking at China and wondering what is actually happening. And for those of us who were closely monitoring, it was really scary because they started to build the hospitals in a few days. They sent over 40,000 healthcare workers to Wuhan, including 20,000 specialists. So there was obviously something going on, but since we all considered China to be so far away, most of the world was just ignoring it. But then it came much closer, and the similar situation started to happen in northern Italy. And then most of the world got scared because at least those of us who are close to Italy know that it's not a third world country, which most of the Americans thought. And then when you see a healthcare system overwhelmed so quickly and so drastically, we all got scared. And when we looked at the numbers, and in the mid-March, they were really rising exponentially. And then there was also an official release from the WHO who said that the case fatality rate based on the Chinese numbers was around 3.5, which assuming the 50% infection rate, which is not unrealistic, would mean thousands of deaths per million. What happened is that most of Europe and big part of the world went in lockdown. So we locked the world, and the countries which did it quickly actually shut down epidemics really efficiently. And Croatia was fortunately one of those countries, because when you look at the beginning of our curve, it was really growing fast. And the question was, how far would it go? And when we look now, we stopped at approximately 500 cases per million. But in Luxembourg, it was 6,000 cases per million. In New York City, it was 25,000 cases per million. So it could have easily went up at least 10, maybe even 50 times. So something which would be quite a realistic scenario for Croatia to have 50 times more infected, 50 times more deaths. Although this is still a little bit questionable because it's not easy to compare numbers in different countries because different countries have a different extent of testing. And one of the key questions which still is open is how many cases were not found? Because when we talk about the cases, these are confirmed cases. So somebody actually tested the person and found the virus. And how many of them we did not find, we still do not know. But something which is still not perfectly reliable, but relatively a bit more reliable than cases are the people who died. And then when we looked at deaths per million, it also varies considerably, and Croatia stopped at approximately 25, while many European countries had 10, 20-fold more, Belgium even 30-fold more. So again, it is quite probable that without doing something, there will be more cases, more dead people. And in mid-March, nobody really know how far could it go. And the first indications saying how far could it go, or are these deaths just the tip of the iceberg, came from New York. And in New York, they were doing extensive serology testing. And even though some of those tests are not perfectly reliable, when we saw the difference between the north of the state and in New York City, we could relatively certainly conclude that at the peak of epidemics, the infection rate in New York City was between 20 and 30% of population. So obviously in the New York City, virus started to spread very early. It spread rapidly before testing even began, and it infected large proportion of the population. And what is worrying is that when you compare the number of people who died with the total population, we can estimate the infected fatality rate. So not the confirmed, not those people which are actually confirmed as infected, but total infected fatality rate to be close to 1%, which means if everybody would be exposed to the virus and maybe between 60 and 80% people got infected, New York City would have between 40,000 and 60,000 deaths. If you extrapolate to Croatia, which is half the size, you're really facing the situation where maybe 10, 20, maybe even 30,000 people who die. New York also started with a quite drastic shutdown, and there was a rapid fall of hospitalization, rapid fall of deaths. And actually, this was the good news, because at the beginning we were thinking this would go even much higher. Because if this is 1/3 of population, then maybe there's just one wave of a similar size. And then when we looked across the world, there were many people who died because of the pandemics. There are some people in the media who claim this is only a virus, this is all a conspiracy, but this is not a conspiracy. There are really excess deaths in many countries, and some of them, like the UK or the US, they're really steep increase in people dying. And it's not only that old people, there are many young people who died. And this is one of the pages in US where they actually put photos of people who died, and you can go and look at some of these concerns about the reality of the situation. And in particular, urban areas were hit. And when you look in Bergamo, there was 5,000 extra deaths in a couple of months. The same thing in Madrid, the same thing in New York and in London. And in all of these cities, we see a sharp decline, which coincides with the lockdown. So one of the conclusions is, yes, we really shut it down with the lockdown. But then there are some other countries like Sweden, where there is still no official lockdown and many things are going on. And even there, we see a decline of people being infected and dying. And actually, sometimes in the media, Sweden is portrayed as a country where so many people die. But when you put it on a scale in Europe, actually it's somewhere in the middle. Many more people died in Belgium, Spain, Italy, and UK than in Sweden. So things are not clear. We cannot be sure what is actually going on. Also, when we look at Japan, Japan did not introduce any lockdown. They just had a 3C policy. So avoid closed spaces, avoid crowds, avoid close contact settings. And just, I think yesterday, they ended the state of emergency because they managed to curb the epidemics. So the thing is, we see that number of deaths is decreasing in most countries. Infection rate is decreasing in most of the Northern Hemisphere, but we are not completely sure why is this happening. And something which is quite puzzling is that when we look at the countries which stopped the lockdown, we see that infection rates are decreasing even after the lockdown ended. So it's clear that at the beginning, what happened in Wuhan and Lombardy and New York, it was the lockdown which stopped the pandemics. But there are some other parameters which also work together with the lockdown, which seem to be curbing down the pandemics. And one of them, most probably, is the seasonality of the SARS-CoV-2 virus. So all previous coronaviruses and most of the respiratory viruses show very strong seasonality, meaning they appear sometime in late autumn, and then they last until early spring, and then they just disappear over summer. But what nobody did in the past was actually testing for these viruses outside of the season. So what we do not know is whether these viruses actually disappear, or maybe people still get infected, but they do not develop disease. And personally, I think that the second is the case. And there is a reason why we called common cold the common cold, because if you go outside in the cold and you're wet and your temperature decreases, you will get ill, but you will not find the new virus there. It's a virus which is already new, which will start spreading. So now I would like to bring you a little bit more to the molecular level and present one of the models I'm advocating for months now. And this is that actually it is dry indoor air, which is one of the reasons for seasonality of viruses. And this is something which is not widely examined. There are a couple of papers. Alemka, Dragan Primorac, Dr. Goric, and I published one paper a couple of actually weeks or months ago about it. And the idea is that, you know, we are fighting the war with viruses for millions of years. Viruses see us, and us is everybody who is not a virus, I mean, from bacteria to all organisms, as a food. And they try to feed on us, and they mutate with an unbelievable rate. And we have to fight it. And we fight it in a number of ways. And one of the ways is that we are different. We are not all the same. And one of the main molecular bases for the differences are glycans, starting from the blood groups to everything else which is on the surface. And by being different, this makes a reproductive barrier for the virus. So, and we never saw a virus infecting everybody. So even the bubonic plague killed maybe 30 or 50% of population in some locations, but it never infected everybody just because we are different. And the second main weapon we have against viruses is something called the mucosal barrier. So mucosal barrier is the surface of our exposed surfaces like mucosas. So our skin is not permeable to viruses, but our nose, our mouth, our eyes are. And then on the top of this mucosal barrier, there is a thick layer of glycans, which is kind of protective shield. And then there is a layer of liquid which flows upwards from our respiratory tract. And in this layer of liquid, there are a lot of mucins. And mucins are highly glycosylated glycoproteins, which kind of mimic our cell surface. They trap glycan, they trap viruses and bacteria, and just take them outside of our body. So it's a kind of a defense mechanism, very similar to the protective walls and the moat which is surrounding most of the medieval fortresses. So you have a thick wall, this is a thick wall of glycans on the surface, and then you have a layer of mucus catching glycans and catching viruses and bacteria and bringing them outside of our body. And this works very fine unless we dry it out. And drying the mucosa out is a new invention. It started to happen when we started to heat our homes, because the humidity in the heated spaces can be very low, because the capacity of air to dissolve water is highly dependent on temperature. So if the outside temperature is very low, even the high relative humidity outside, so you can say it's a winter, it's moist outside, it can be 100% humidity outside, but if the temperature outside is maybe 5 degrees or 10 degrees, when this air goes into your room and you warm it up to 25 degrees, then the relative humidity falls at approximately 20%. And this 20% relative humidity is very dry air. This dry air, when you breathe it, it takes water out of the mucus in your nose and your throat. It dries out and it does not work anymore. And we all know this experience after sleeping in the winter and waking up and our throat is sore, it's dry. And this is one of the problems, and this is how viruses can amplify, not only infect person, but also amplify within a person and move from our nose down towards our lungs and cause disease. And now the question is, with all this knowledge, what can we know and what can we say about the second wave? What will happen next? So when we look at influenza pandemics, the Spanish flu, there are very different situations. There were some cities which had a very strong first wave, and then a little bit or nothing later. Some had a first and then a second. Some of them had the very similar ones. Somewhere the second was higher than the first, and there are several parameters in the game. First is, of course, how many people got infected in the first wave. So if we think about New York or London, where there is between 20 and 30% of people already infected, they can only get maybe the equal size second wave, probably the lower. In countries like Croatia, where we are probably below, definitely below 5%, probably around 2 or 3% of people who are infected, if the virus starts to spread, there will be a big second wave. And I think the biggest question we have now is it really seasonal nature which is bringing it down? And if it is, then we can relax for a couple of months, but we have to prepare for what is happening in the autumn. And the best way to know that would be to look at the southern hemisphere, because in southern hemisphere, the winter is coming. It's the mid-autumn there. And the country which is actually worrying me a lot is Chile, because Chile had a very strict lockdown in the beginning. They managed to contain the pandemics during the late summer and early autumn there. But now as the temperatures are falling, despite a strong lockdown, and now they introduced even worse lockdown, the numbers are just rising. And both the number of infected and the number of hospitalized, the number of dead people. So we have to follow this trend. We have to see whether the same will happen in Australia. But if this really happens in the next few months, we have to prepare for a pretty bad second wave and plan how we are going to survive it. And slowly towards the end of my talk, I will just tell you a few things we know, because everything before what I said is, we are guessing and we are hoping. But what we know now is that when we look all around the world, this infected fatality rate is much lower than initially thought. It's probably up to 0.3%, a little bit more. And the worst thing to be is old male. So if you're old and male, the risk is very high. But the age is the strongest driver. It's over 100-fold difference if you are below 39 and over 80. And there is a gradient. And everything else is not so important beside obesity, but really extreme obesity is something which is a big risk factor. Moderate obesity is not that bad. It's maybe 50%, like being a couple of years older. Uncontrolled diabetes is something which is tough, and some kind of leukemias or maybe organ transplant. Everything else is not a significant risk. People were afraid at the beginning because diabetes was declared a risk, hypertension was declared a risk. Actually, they are not major risk factors. It's mostly age. And we are currently, we, the planet, are trying to find the better biomarkers, and I hope by autumn we'll have them. And just to finish, several thoughts. First, the COVID pandemic is real. It's not, somebody, can you please mute your microphone? Somebody is talking in the background. So it's a real pandemic. The social distancing is the only tool we have at the moment. There are no reliable drugs or vaccines, and we'll not have them by the autumn. We still don't know how effective are which measures in different cultures. We cannot just copy Japan's principle to Croatia. And it will take years to evaluate the cost effects of all different measures. So we shouldn't be judging of our government. And we are getting better treatment, but there will not be a vaccine. There will not be a vaccine by autumn to save us. But importantly, COVID-19, it's not a bubonic plague. It will not kill everybody. We have to go on. There will be some people who will get ill. There will be some people who will die, but we cannot stop the planet. We just have to be careful. And with this, I will end, and thank you for attention.
Thank you very much.